Warm welcome to everyone. As we were seeing, first we have seen about what is pain, what is that you all need to know. Then now we will see to some extent the initial phases of management. I will try sharing, Sinia. If there are issues, then I will ask you to share. Is that okay?
Sure, ma'am. Please go on.
Okay. Just give me a minute. Can you all see?
Yes, ma'am, we can see.
Okay. So basically, what we are going to see today is management of pain. Okay, as I had told you in the beginning, pain is like nearly we say 60 to 80% of symptom management in palliative care, be it cancer pain, non-cancer, be it a cancer patient or a non-cancer patient. In any type of patient you take, 60 to 80% will be pain and breathlessness. So pain forms a very, very important. That's what we say 60% could be. Pain will be the symptom in any group of patient that you will be getting under palliative care. And in that one, how are we going to manage it? For that, we have something called as a WHO ladder. Okay. Why are we using it? What's the significance of it? Is all what we will see initially, and then we will go into the management also. So this WHO ladder is based on the recommendations of a group of international experts. It's not one or two people, and they don't miss anyone because regional difference, regional diseases, regional presentation, everything is quite varied all over the world. So some individual changes and differences will be there, but that has to be kept in mind. So just give me a minute. So keeping that in mind only, this is implemented. And as I said, it has international experts. There will be eminent people from all parts of the world who will be in the committee of making the recommendations. So that is the first thing. And what WHO did in 1986, they devised a step ladder approach to manage cancer pain. And that got translated into 22 languages and served as a catalyst for treating cancer pain worldwide, not in one part. As I said, international experts. So the benefit got translated or conveyed or made easy for the whole world. And why is it so useful for the whole world? Because it is simple, well validated, and effective too. So all three are important. Anyone can use it. And well validated means that is why international experts have been part of the team. So they have made sure all the hitches or whatever were the problems or troubles, they were all troubleshooting was done before release or before recommending itself. And next, it's effective tool means they have already done studies and proved that it is effective. So all three important points are mentioned here. It is simple, so everyone can use, well validated. So no need to worry whether it will work, won't work. Those type of queries need not be in anyone's mind. An effective tool. They have found it to be very useful. it is a stepwise approach to treat cancer pain depending on severity. See, these are important points. As we go through also, we will see. Step ladder approach legitimizes the use of opioids because use of opioids has always been a challenge or one blocker or something causing obstruction or hesitation in people using it. So that also got legitimized. So opioid usage was legitimized based on this. So the WHO method, generally this whole WHO aspect or methodology can be summarized in 5 phrases. The important things are by the mouth, by the clock, by the ladder, for the individual, and paying attention to detail. We will see one at a time. So I said this was a simple method. Okay. So one of the important, see, all these 5 phrases have to be followed strictly. Only then the benefits. I said it was simple, effective, validated. It will answer or it will keep up all those phrases only if these 5 are followed in this method. By the mouth means it can be given orally. By giving orally itself, you will get maximum benefit. Because many people have a, sorry to say, wrong or a different idea. Oh, injection works, tablet doesn't work. It is not the truth. For that, we have to practice in the first place. If we say, see, generally, today's world is slightly different. Generally, if a doctor says something, patients, family, everyone believe, have faith. So we have to start saying and practicing that by the mouth, it will work equally and effectively. So especially the medications recommended by WHO ladder are very effective when given by mouth. Okay. Next is by the clock. For this, I'll give an example. You say patient has to take tablet 4 times. They will take 2 times and come and say, oh, doctor, medicine never worked for me. I have been taking it 10 days. Then slowly you ask, oh, how did you take? So if you ask what's the benefit? How is the medicine working? Then we say, no, not at all working. Then we have to ask further questions. Oh, okay. Then how have you been taking? I took only twice. Then you'll say, no, we had asked you to take 4 times. Oh, you said, but I thought this is enough. So something like that they can answer. They may say, I didn't have money to buy. Many answers can come for that. So why? We have to explain to them why by the clock. Because only each medicine has some duration of action. For example, in this morphine, when it is given orally, it is said to work only for 4 hours. Okay. So it is normally said, for example, I'm taking example as morphine. If it is any other drug which acts a duration of action of 6 or 8 hours, then you have to say it should be taken only once in that 6 or 8 hours. For morphine, it is once in 4 hours, because if the duration of action is 4 or 6 hours, and they take opposite, for a 4-hour duration of action, if they take it once in 8 hours, for a 6-hour duration of action, they take once in 12 hours. See, only 6 hours it works. The next 6 hours, it will not work. It is false to expect it to work. So that is something we have to explain to the patient. And next reason for why that is this, whenever you want to give medications and the patient needs to get, for example, pain relief, the drug has to be in the blood circulation. Okay, the duration of action is the time when the maximum benefit will be there. For some drug which has duration of action of 4 hours, and you give once in 8 hours, the next 4 hours, the plasma level will be nearly 0 or minus. Will the patient get any benefit? No. So in that case, we have to see. That is why we insist on by the clock and by the ladder. Why the ladder means we will see. If it is step 1 means you give step 1 or step 2. The exception what we will be following, I will tell when we come to it. For the individual, here again it is important. Okay, you have one patient weighing 50 kilos, another patient 150 kilos. Will you give same medicine dose? Someone can answer. For a 50 kg patient and a 150 kg patient, will you give same dose?
No. No, ma'am.
So that is individual. One example, weight. Another example. One patient has some renal problem. So renal parameters are not normal. So for him, will you give same dose as someone who is normal?
No.
Liver failure. So basically, that is where individual variation comes. Some other drug interaction. Nowadays, you have polypharmacy. You have to make sure what are the medications the patient is on, whether any drug interaction possibility is there, all that. And this renal failure means you have to reduce the dose or increase the duration. Why? What does the kidney do? What will a kidney do if someone is taking some medication? What is the function of the kidney?
Ma'am, can you please repeat the question?
See, like for example, someone is having kidney failure. I said you will not give the same dose. I asked what is the function of the kidney when someone takes any medication?
Excretion, mainly excretion.
Very good, very good. What is the function of the liver?
To metabolize.
Metabolism.
Very good, very good.
Metabolism.
So if someone has liver impairment, so liver functioning is not normal. So metabolism is going to be affected. Someone has renal problem, excretion. So if excretion is affected, what will happen to the medicine?
It will remain in the circulation.
Very good. So
Increase
it will
the
remain, it will, for example, this 4 hour, what I was telling, there, because kidney is not functioning, the drug may remain for 8 hours. Even though the normal action is only 4 hours. There, because that is where this, for the individual, I have patient A who is normal. I have patient B with bad renal function. So even though I'm going to use the same drug, I will not give instructions same for patient A and patient B. So for patient B, I will say, take it once in 8 hours. That's all. So either you prolong the duration. So for someone you're giving it 4th hourly, you can make it 8th hourly. Or you're giving 10 milligrams for A who is normal, you can make it 5 milligrams for someone who is having renal failure. Okay. This is for the individual. Okay. And then attention to detail. That is where the drug interaction or any specific problems with that particular patient. They may have some idiosyncrasy, like some allergy, something different, or very old, 80-year-old and 30-year-old. Will you treat the same?
No, ma'am.
Yes, sir. So 80-year-old, everything, first weight may be low, all their functioning will be low. For them, 1/5 the dose also may give the same benefit as a normal 30-year-old. Okay, so those are the things. In this 5 point, have all of you understood everything? Because this is very, very important. If not, I don't mind repeating it. Sinya, either you see what comes in the chat box, Sinya, because
Yes,
me
ma'am.
personally from my iPad, I cannot see the chat also.
Yeah. There are no doubts or questions in the chat, ma'am. If anything
Okay.
comes up, I'll inform you.
If there's anything, please let me know. So if everything, is it all clear or you want me to explain once again? Someone can respond.
Clear, ma'am. It's all clear.
Okay, if anybody is having any doubt also, no hesitation. Okay, because understanding and moving forward. If all of you have to practice, no, you can't have doubts and then start practicing. Okay, so fine. Okay, oral route is the preferred route for all analgesics, including morphine. For persistent pain, analgesics should be taken at regular time intervals and not as needed or as required. This statement only I gave that so much explanation because blood level or plasma level, we call that as pharmacodynamics and pharmacokinetics. Basically, this what we discussed, any drug is metabolized by the liver and excreted by the kidney. So this has an impact on the time and everything. So that is why I say, because many people say, oh, I will take the tablet only if I have pain. Then what will happen? We call peaks and troughs. When they take, it will work for example, it will work only for 4 hours. Okay, they will take it, they will have relief. And then they will leave it to a stage when the pain becomes very high and then scream, oh, this drug worked only for this time. I was in agony again. So why? You did not take it properly. See, I am not blaming any patient. Don't mistake the way I'm telling. So our duty or responsibility is to explain to them. That's why it's mentioned not as needed. If you want continuous pain relief, you need to take continuously. Again, see, we are not going to constantly telling only medications. As through all your sessions, you will see for everything and anything, we have pharmacological management, non-pharmacological management also. So again, multimodal management. We will say take medicines when it is really bad. Use the other modes also as you feel better. So as we see, we will see when we see all the drugs and things. So when your pain is very bad, you're giving medicine, you need it. And especially if it is cancer pain, the pain is really intense. And if they don't take the medicines regularly, they will not be able to function. So our main aim of palliative care is to maintain quality of life and to improve the functionality of every patient till the maximum time that we can, and so that they have better quality of life. Okay, so you have to explain all this and then tell them why you are asking them to take it regularly. So now comes, what are the advantages of the WHO lab? Simple and easy, it is validated, effective, universally accepted, can be used for cancer and non-cancer pain. And it is also well suited for home care. These are the salient points which make this WHO ladder as a universal all over the world. It is used. And another important thing is, if there is, see, I'll give simple examples. 2 times table, 4 times table, 6 times tables and all of that. So they are all standard. Like that, if you have something simple and easy, and the whole world can follow one thing, is that not easy? Does that not make our life easy and simple? So that is the biggest advantage of this. And this is what is the pain ladder. Okay. You have a look at this. You have to have this in your mind as we go through our session, the whole session today. So you have step 1, and in which you have non-opioid analgesics. And in every step, if you see, there is plus or minus adjuvant. Then next step is step 2, where you have weak opioid, plus or minus non-opioid, plus or minus adjuvant. That is step 1 and step 2 together. Then you have step 3. See, where you have only strong opioid and non-opioid plus or minus adjuvant. See, 1 and 2 can be combined. 2 and 3 are not combined, but 1 and 3 are combined. Is that clear? This is very, 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 very important. Okay, so many I'm telling because you have to understand this clearly. I am going to repeat once again. You have step 1, step 2, step 3. These steps are divided based on the intensity of pain, which we will see in the coming slides. So step 1, what you have is non-opioid analgesics plus or minus adjuvant. We will see what is an adjuvant during the course of the session. Next is step 2 is weak opioid, plus or minus non-opioid, plus or minus adjuvant. So 1 and 2 can be combined, step 1 and step 2. Whereas see step 3, it is strong opioid, plus or minus non-opioid. So step 3 and step 1 are combined. An adjuvant is there in all these steps. You can add an adjuvant in all these steps. Is that clear?
Yes, ma'am.
Okay, thank you. Then coming to see, as I said, you have to have a pain assessment to decide which step we are going to use. This we saw in the previous session, like whenever you do pain assessment, you will ask for site, nature, extent, aggravating factors, relieving factors, radiation, impact on sleep, impact on personality, everything we have seen. So that is why understanding what is pain, understanding and knowing how to assess pain is very important. If you don't know how to assess, how will you treat? And we are going to use this ladder based on the assessment. Okay. So again, pain can be mild, moderate, or severe. So we have seen that 0 to 10 scale or patient explaining, whatever it is, you can have these types. So based on that, if the pain is mild, you will use step 1. If the pain is mild to moderate, you will use step 2. If the pain is moderate to severe, you will use step 3. Normally, if the pain is moderate, as I said, you can combine, either use 2 or combine 1 and 2. If the pain is severe, if, for example, when you're seeing it, so the patient comes and tells pain score is 9 by 10 or 10 by 10, you can skip 1 and 2 and go to step 3. So that is the only thing to understand. Otherwise, we will go step by step. If it is mild, start with 1, wait, treat, and it might settle with step 1 drugs itself. If it is moderate, you can go to either moderate group drugs, that is weak opioids, or combine 1 and 2. Whereas if you're seeing itself in a stage of severe pain, you can straight away go to step 3 also. That is the important thing. So my assessing the pain is going to help you to decide which step of drug you're going to use. So that is the important thing there. Okay. So coming to step 1 and 2 drugs. In step 1 and 2, we have paracetamol and NSAIDs. Paracetamol. Paracetamol is well established as an effective and well tolerated agent for mild to moderate pain, both as a single agent and in combination. So paracetamol is a very common, simple antipyretic. Okay, it is antipyretic and analgesic. Only thing, it is not an anti-inflammatory agent. That is what you have to understand. It is antipyretic and analgesic, but not anti-inflammatory. So again, it can be used separately or in combination. Both can be used. But only thing, either as a single agent or in combination, you should be aware of few things which we'll see next. Generally, it has very minimal toxicity in adults at the normal recommended doses. But at higher doses can cause fatal hepatotoxicity and renal damage. So you should be very clear with the normal recommended maximum dose, which is 4 grams in 24 hours. That is the maximum. Again and again, I'm telling you have to see with the body weight. 10 to 15 milligram per kilogram body weight is the maximum allowed. Okay. So like that is what you have to decide and give. The 10 to 15 milligram kilogram body weight is the single each time dose. So max, so for example, that's why normal weight, by weight, it is 10 to 15 milligram per kilogram. But the maximum dose in one day is 4 grams for 24 hours. Okay, because 4 to 6 hours they can take. So that is why you need to know the each time dose and also the maximum allowed dose per day. And what is the general toxicity, what is maximum, both I have explained. The risk of toxicity with paracetamol increases in patients with pre-existing hepatic impairment or low body weight or nutritional compromise. So generally paracetamol is safe. So you're thinking like that, but you're not aware of any of these. Someone is only weighing 30 kilograms. You give 4 grams per day, that is, you're inviting trouble and problem with open arms. Okay, so that is why these 3 points are very important. Or someone has hepatic failure, for them you should not give. Or nutritional compromise, they are skin and bone, some poverty or something like that. So all these, the previous slide we said what is the general dose, what is toxicity and all we said. But you also have to have in mind these factors. If any of these are available, you can't generally say, oh, I was told I can give 4 grams. But that's why these also have to be kept in mind. Next is NSAIDs. NSAIDs are a heterogeneous group of drugs which produce their analgesic effect through inhibition of one or both of the isoenzymes of cyclooxygenase COX-1 and 2. Okay, so basically they are a group of drugs which give the pain relief through inhibition of one of these isoenzymes, COX-1 or COX-2. In that, you can have selective COX inhibitors. So, example of that is aspirin, ibuprofen, and diclofenac. See, these inhibit both the isoenzymes. Some aspirin, ibuprofen, COX-1, and then diclofenac, COX-2. But even though they are said to inhibit these, their use is associated with number of adverse effects, which are GI complications and renal toxicity, which has to be kept in mind very, very clearly. Okay. Generally, both of them, COX-1 and COX-2, have their own plus and minus. Okay. If it is COX-1, GI disturbance is very common. And COX-2 is said to have less GI disturbance. And the renal toxicity is said to be there for both. They are not free of renal toxicity. Okay, so in the coming slides you will see, still we use them, but we have to be very clear how it has to be used, when, what, everything. Selective COX-2 inhibitors such as celecoxib are associated with reduced GI effects, side effects. So next thing, all NSAIDs may provoke or worsen renal failure. Okay, if someone already is having some problem, it will make it worse. Or even though if someone was totally fine, they can have, or it can cause renal toxicity. Okay, and many evidences have also shown NSAIDs can cause cardiovascular risk also. So GI, renal, cardiovascular, all 3 systems can be affected. But generally, NSAIDs are used right, left, center. Okay, and many people don't even see a doctor. They just go straight to pharmacy and buy and have. What has that cost? All of you will be knowing. And in the last 2-3 years, when I have been in many places, there are 30-year-old people who are on dialysis. It is really a pathetic condition, I would say. I have seen so many 30 to 35-year-old who are on dialysis 3 times a day. Dialysis 3 times a week. See, that reduces the quality of life of a person. it is a burden to him and the family with cost, his quality of life, his day-to-day activity. He can't go to work. If you slowly ask them what, they would have been taking NSAIDs for months or years. And sometimes, as I said, individual variations. Some people may have some autoimmune or some form of changes within them which they may not be aware. So they take right, left, center, any medicine whenever for any ailment, one NSAID. And that too not 1 or 2 days. Oh, I've been taking for 6 months, 6 years. That will all result in these type of complications. So it is our duty to impart the knowledge. How and when also in my next coming slides, I will tell you. Topical NSAIDs in the form of gel or patches have been shown to provide effective analgesia in acute musculoskeletal conditions such as sprains. Even like joint pain also, we say topical NSAIDs in the form of gel or patch, whatever is available, okay, can be used to give adequate pain relief. What is said is generally there is no 100% evidence, but it is said that when you apply it topically, the systemic absorption is relatively less than when taken orally. So that is the plus point. So topical NSAIDs, like many times, like when they take it orally, they can take it orally for some time, and then when it is really bad, take it orally. Then recommend them to apply as ointment or gel and give some hot fermentation, or apply the ointment or gel, give some time and do some exercise or physiotherapy. These are things which we have to convey to them. And not, if we don't tell them, they may not know, and they may end up having renal failure. Once it gets to a stage of renal failure and not correctable, then no one can help. So this is like a nutshell slide, how you can use the NSAID. The lowest effective dose should be used for the shortest duration required to control symptoms, and the need for ongoing treatment should be reviewed regularly. I am going to read this once again because again, this one, at least all of you take this message from this slide, no? I will be so thankful, because it is not only the group who are attending now. If this gets passed on to the community, at least, as I'm telling, we will not see again and again people who are 30-year-old to have renal failure. Okay, the lowest effective dose should be used for the shortest duration required to control symptoms, and the need for ongoing treatment should be reviewed regularly. So what is it telling? For example, someone gets relief with 200 milligrams 3 times. Fine, continue that for 3 to 5 days. Lowest effective dose should be used for shortest duration. Acute pain, use it, then stop and use the gel or do exercise. You have to teach everything for them. Use it, use the lowest dose, that is not just lowest effective dose, for shortest duration until you get control of symptoms. Okay, that is first part. And then the next part is what? Not take like a chocolate or a biscuit or like a sweets through like 2 years, 3 years. So need for ongoing treatment should be reviewed regularly. So one doctor prescribes it for 5 days. Okay, but it is taken for 500 days. Is that right? See, someone can answer, like, am I telling something which is out of the way, or do you all agree with this at least? Agree, disagree, anything is fine. But speak up and tell me, is my statement wrong? You can disprove me if you have good evidence. What is your opinion? Anyone can answer. Am I telling something which is not there, or What is that you all see? You are all practicing people, no? So what is that? Do you see something totally different to what I've said? In Uttarakhand, isn't it? All of you are. So you don't have renal failure patients at all, or do you see what I am telling? Any message in the chat box in here?
Yes, ma'am. Surabhi is saying, yes, ma'am, I agreed. Anjali Best is saying duration should be short.
Okay. Because see, why I'm telling is like 6 or what, 8 months ago, last year, December, when we were in, like from Palayam, we were in Tirupati, where we did a 10-day course, and we had very close interaction with the nephrology department in that SWIMS Medical College and Hospital, where we got to see plenty of patients who were on dialysis. And we also did home visit, where one of our patient was a 32-year-old. He was living with his mother. Why? Because 32-year-old was having dialysis 3 times a week, and nobody else was supporting him. His mother and himself only. He was, even with that, but he was taking it up all in such nice spirit that he was having dialysis, but him and his mother were meeting ends of day-to-day living. And he only told me, he said for many years he was taking tablets. Oh, I did not know, madam. I needed pain relief, so I want one prescription. I will go and get it from the pharmacy by myself. After that, I didn't go see any doctor at all. Then I became very bad because the nephrologist was the doctor who took us for the home visit. And then he told us there were like hundreds of patients like him. So I am not creating stories from the air. Okay. So that is why. Okay. So please understand, if anyone has any different, I'm not telling that you should not use, okay, because this is a very useful drug. Use it for some time, then give a break. We'll see the other adjuvants and things. You can use something else, use exercise, teach them physiotherapy, teach them about, as I told you all in the first session, why is the pain like this? And there is something called as total pain, which I will show you also. That there are so many elements which can be the cause for pain. Okay, and use it for short time, use something else, and then 2-3 months, 6 months down the line, suddenly one day he does something, some excessive work, or he walks 10 miles. That day he may have pain. That time use it for 2-3 days. Stop. See, I am not against. NSAIDs are very effective and useful. I myself, being an anesthetist, I have used it even intravenously. Post-operatively, when I cannot tackle or manage the pain, I have even used it IV. Okay. So it's not that I am against it or I'm teaching her not to use it. Use it wisely. Again, I'm going to read this slide. The lowest effective dose should be used for shortest duration required to control symptoms. See, everything is said there. Effective dose, short duration to control symptom. If symptoms are controlled, that is our aim and goal. And next thing is that the need for ongoing treatment should be reviewed regularly. Just don't write on prescription and leave it for 10 years. Okay, you got relief, stop here, do something else, use it to as and when required. Here, as and when required will work. Not in the WHO ladder where we said opposite, it has to be taken regularly. Okay, so you should know. See, one size fits all, if it is one type of prescription, all we take, then there's no charm or expertise in medicine. Everyone can be experts. Why still there are someone who get maximum? Because you have to understand, impart, and get the benefit conveyed across to the patients. We have to understand everything clearly first from our point of view, and then be able to tell it to our patients so that they get the benefit. So that is why you have to tailor make, we say. See, one size, does it fit everyone? Do you like wearing something like that? We don't. So like that, we have to tailor make it to the need of the patient. Next group is weak opioids, in which you have two drugs mainly, tramadol and tapentadol, which we will see. First one, tramadol. Tramadol displays weak opioid activity, and it is also a noradrenaline and selective serotonin reuptake inhibitor. It is available in tablet injection form, usually started at the dose of 50 milligrams twice daily or 3 times daily. And in this also, the maximum dose is 400 milligrams per day. You always
Radha ma'am. Ma'am, can you hear?
No. Anything else? Okay, water, hot water therapy.
Ma'am, we can
Change
provide
the
them
situation.
comfortable position.
Can you please
And-
repeat? Can you please repeat? I didn't hear.
Ma'am, we can provide them comfortable position.
Yeah, of course, we can provide them comfortable position. So, like one important thing is that whenever the patient is pain, we know that if a mental patient is there, we cannot touch the patient without asking permission, right? So, when a person is in pain, a single touch, like in a palliative aspect, we can provide a single touch and calm them. That single touch will be a step towards to opening the mind, we can say, right? If is anyone felt that kind of thing?
Ma'am, we can manage the pain of those patients by using scales like visual analog scale, by facial expressions.
Yes. Yes, of course, we can use that also. We are dealing with the total pain, right? Physical pain, social pain, spiritual aspects are also we are figuring out. So, total pain, we are covering it. So, one by one, we will get to know by communicating. We'll tell the patient to ventilate their feeling, what they are expressing. So, pain, as we have studied, there are different things we have to calculate for pain, right? So what all things you will collect, what all information you will gather to assess the pain? It's a previous class question. Previous class, the class was superb. Madam was taken in a very well explained. So what kind of if you are assessing a pain, then pain can be what all aspects you will consider?
Same ma'am, site of the pain, nature of pain, extent and aggravating factor, etc.
Yeah, of course. Then anything else you want to add on, left out?
Relieving factor.
Relieving factor, provocating factor. Yeah, so these all things has to be then along with that we can use the scale also, right? So pain scale we can add on that. With that we can get what is the pain score the patient is having. So what are general medicines in your area you are getting?
Ma'am, paracetamol, ibuprofen, diclofenac.
Yeah, okay. Thank you for your response. So ma'am has joined. So we can continue the topic.
Radha ma'am, can you please unmute?
That's all. You will have to do the presentation from your end. I think this Wi-Fi is not working, dear.
Please confirm the slide.
You keep going. Next one. We were in. Next one. We were here. Thank you, dear. So As I was telling, tramadol also, if you're using combination, you should make sure that you are not keeping an eye on the dosage, allowed dosage per day, so that you don't exceed. Okay, next slide, please. Next is tapentadol. It is also it is very much similar to tramadol, but literally mechanism of action, everything is the same, and it is available in strength as 50-100 milligram tablets, and mostly maximum dose, everything is like tramadol. Only thing, availability, in some places it's available, some places it may not be available, but the preparation, usage, everything is like tramadol. Next slide, please. Adverse effects. Main adverse effects for both are, that is for step 2 drugs. It is, see, for step 1 drugs, we have seen paracetamol, NSAID, we have dealt in detail what are the complications. Now, step 2 drugs, normally the most common complication is nausea, vomiting, dizziness and drowsiness, hallucinations and confusion. And the third one is one of the important things. Seizures may occur with use and appear to be most likely in people taking drugs that lower the seizure threshold or who have a history of seizure. So for those type of people, you have to be careful when you have someone who has history of seizures or they are taking some other drugs. Then you cannot increase the dose of this. So because in the previous slide, as we saw, it has an action working on the SNRI receptors. So norepinephrine and SNRI receptors. So you have to use them carefully. So generally, if the seizure threshold is lower, and then by other drugs, and this drug also has that tendency, then probability of patients having seizure as side effect is there. So you have to keep that in mind when you're using this. Next slide, please. Next comes adjuvants. We were seeing in all these slides, adjuvant. So what is an adjuvant? Next slide. Definition. An adjuvant is something which helps, literal meaning is something which helps or facilitates. Anything that helps or facilitates treatment is called as an adjuvant. Next slide. So the mechanism of action of an antidepressant drug in management of neuropathic pain is unclear. Analgesia is, what happened is this antidepressants can be used as adjuvant. Okay, so basically adjuvant is something which helps or facilitates. So it is directly not a painkiller, but it helps to reduce the pain. So commonly used one is antidepressant. The direct mechanism, how it works is not clear, but it helps to reduce the neuropathic pain or nerve pain. And analgesia, main important point to understand is the pain relief is obtained with very low dose, not the common dose used for the antidepressant action. So generally, the antidepressants are given in 75-100 milligram dose, but what we use for pain relief is 10 milligrams. So the dose is very low and still gives pain relief. Next slide. In this group, you have plenty of drugs as adjuvants. So we will see a list of many things. Commonly used antidepressants are tricyclic antidepressants, SSRI and SNRI. Okay, next slide. If you see the analgesic efficacy, like all the 3 groups which are used, the tricyclic, common example of tricyclic is amitriptyline, nortriptyline. So that has the maximum analgesic or effect to help with pain relief. Then the next group is SNRI and the next group is SSRI. Even for side effects, it is the same. So
Radha ma'am? Ma'am, we can hear you.
Hmm? Excuse me?
Ma'am, we lost you for a second.
No, because my Wi-Fi has just come. Give me a minute. Sorry, Sinya, I will come back to
No
the.
issues, ma'am.
Okay.
Okay.
Because it was just my Wi-Fi coming. Because when Wi-Fi came, this got.
Understood, ma'am. Please take your own time.
No, no problem. Sorry for all this. This is all technical glitches. Okay. Thank you, Sinya. We'll continue presenting from your end itself.
Yes, ma'am. Okay.
So the contraindications, what we are seeing is they can have cardiac conduction defects. So if some patient has atrial fibrillation, arrhythmia, heart failure, in those patients, you better avoid these antidepressants. And someone has benign prostatic hypertrophy or narrow angle glaucoma. These are the contraindications when you're going to use this group. Next slide, please. Next group is anticonvulsants. Why are they used? The reason is epilepsy and pain in both, it is hyperexcitability. We saw why the pain is increased, amplification, all those things which we see. That is why physiology, pathophysiology is so important. Sometimes you may feel boring to read and know all that, but if you don't know that, how will you know to manage? So that hyperexcitability, what happens in epilepsy? Anyone can tell. In epilepsy, what happens? What is the reason for epilepsy? See, you all have to, being interactive is useful for all of you too.
Ma'am, hyper excitability of our neurons.
Central nervous system.
Central nervous system.
Increased electrical activity. Good, thank you. So, the same thing only happens in the nervous system when due to pain also. We saw some extra path, we saw ectopic, collateral, all that happens. One stimulation, 3, 4. Like one person is asked to speak, 10 people speak. Like that. So, because the pathophysiology is hyperexcitability, we use that itself to understand or dampen it. So, anticonvulsants, the main action is to control or reduce hyperexcitability. Again, that same function is used again in low dose, very, very low dose. For example, for epilepsy, they may use 200 milligram 3 times, 300 milligram 3 times. Whereas for when you're using it for pain relief or as an adjuvant, we will start from 100 milligrams 2 times or 100 milligram once, something like that. So that is the important thing why it is done. And then most commonly used anticonvulsants are gabapentin, pregabalin, sodium valproate. Next slide, please. So this is a simple difference between gabapentin and pregabalin. Main thing is that oral bioavailability is not very good in gabapentin, whereas it's good with pregabalin. And slow titration is effective with gabapentin, whereas pregabalin is quick, slightly better in 2-3 steps. Main difference comes next. Gabapentin is less expensive, pregabalin is very expensive. It depends, see, very expensive in the sense, it depends on what is the financial capability of your patient. Okay. Based on that, this very less, more, all that varies. Next slide. Next very important group is corticosteroids, especially in cancer pain, neuropathic pain. This nerve pain in cancer pain forms a very big chunk. 40 to 60% of cancer patients can have neuropathic pain or nerve pain, either due to the disease itself or due to chemotherapy or due to different types of treatment that they go through. Very common is many chemotherapy medications can cause neuropathic pain. Okay, so this group of steroids are said to play an important role. So in neuropathic pain, bone pain, headache from raised intracranial pressure, arthralgia, pain from obstruction of hollow viscous or organ, pain from spinal metastasis. In all these situations, steroids can help. And what is the first line? Dexamethasone is the first line drug. It has a long duration of action. And so generally once daily dose is given, and it has less mineralocorticoid effect than the glucocorticoid. So only one important thing is what is highlighted here. Steroids can cause insomnia. So because normally we all have something called as a circadian rhythm. Can anyone tell just one or two sentences about it? Anyone? I don't want full history, geography and all. I just want, what is it? What is it? What does it mean?
Ma'am, can you please repeat the question?
What is circadian rhythm?
Ma'am, the daily 24 cycle rhythm that includes sleep-wake cycle and
Very good. Thank you very much. See, do all of you sleep night or day?
Ma'am, night.
Why don't you sleep 8 hours day and every time be awake only in the night?
Ma'am, because our pineal gland works on it.
See, there is a hormonal cycle. That is what is circadian rhythm. Basically, our hormonal levels are high through the day and they come down from evening to next day morning. There are very many important reasons for it. Okay, that sleep is so very essential for rejuvenation. If we don't sleep for 3 days, see what happens on 4th day. We will give up everything and ask, oh, if I get my normal sleep, it's enough. Because all our systems on a daily basis need rest. Many important activities happen during that sleep time. If you don't sleep and keep on working 24 hours, you will know how efficient you'll be on 3rd day. So this cycle is very, very important, and that is maintained by the hormonal level in our system. So if normally one cycle is there, you should not break or cause trouble for it. So even the steroid what we give, we try to give it as once daily dose. Latest we'll say by afternoon. Later than afternoon, you don't give the steroid. Because if you give something like that, it can hinder everything. And also, not only evening, if you give steroids for very long period, it can cause many complications also. So normally here, our use of steroids is pulsed, short pulse for few days, few weeks, like that we will use. If you're using for more than 3 days, you have to taper it. Start and one dose, taper it and stop. But if you're just going to use it for 3 days, 5 days, maximum only 3 days or 5 days, you can just use it for some time, especially in cancer patients or in very seriously life-threatening, life-limiting illnesses. For some particular, as I said, I have stated here on the left side the indication. In those type of things, short pulses, you can just use it for 3 days, 5 days, as a single one-time morning dose. And then, or if you're going to use it for 2-3 weeks and all, you have to use the normal method of tapering, starting it, giving one dose, bringing it to half, like reducing by half, and then stopping. Okay, next slide, please. These drugs I've just mentioned there because these are also used as adjuvants, ketamine and local anesthetics, only by expertise, not by anyone and everyone. Next slide. So here is a quick, what are the multiple drugs we have seen. How and when some specific ones I've mentioned here. For pain and other symptoms, these are all used. Antidepressant, steroid, antispasmodic, topical agent, alpha-2 adrenergics, cannabinoids. Many of these mentioned here are used. So on the other side, you've got for neuropathic pain, antidepressant, and antidepressant is the first line. Anticonvulsant next, then NMDA antagonist, local anesthetic. For bone pain, bisphosphonates and calcitonin. For musculoskeletal pain, muscle relaxants and GABA. For bowel obstruction, you have something called as octreotide. So this is just an idea. We have seen many drugs and how and when they are used. Next slide. So this is a nutshell of what you need to know. And one more thing I will try to share, Sinia, one more thing I wanted to share with them. Just let me get my system up again. Oh, you have to allow me to share, Sinia. It says only host can share.
One second, ma'am. And can you please try now?
Yes, you have made me co-host. Thank you. Can you all see now?
Yes, ma'am. We can see the total play slide.
So like what I want to convey in this is, they've been telling pain, defining pain, everything. So what is total pain? Total pain has all these components. It has physical. We have been telling this, but see, always I try to say, all of you remember certain things very well. That it has what we see stays with us for long. Physical, psychological, socioeconomic, and spiritual. So physical has physical pain, fatigue, lack of sleep, difficulty in walking, all these. Any physical symptom will come under that. Psychological, isolation, emotionally weak, depressed, not knowing what's happening, because so much of uncertainty. Okay. And then you have socioeconomic, breadwinner, I don't have money, my house is not right. That overtakes the physical also many times. And spiritual, loss of faith in God. Why me? What did I do wrong? Oh, I was very bad. That's why I'm getting all this. Okay. So those type of things. So that is something which all of us have to have in mind when we are looking into, when we are either even like, so whenever you are going to have something, whenever you're going to assess someone for pain, you have to have all this in mind. So you assess the physical element. That is why we again, through your sessions, all your sessions, you will know, you will be covered on all of this. So that is why your assessment is not complete if you have not touched the other elements. Just physical alone will not do. Many times they do. I would be even say either they may have an equal role, or sometimes socioeconomic problem may overtake the physical element. So you give medicine, no benefit at all. Still same. Then you have to think always, as I said, If you're having no benefit, go back, reassess. When you reassess, you have to look into all this. So many times we commonly say, we have seen many patients, they'll say initially pain score 5 or 6. Okay, start medication. From 6 to 4, it's staying at 4 only, no change. Then we'll think, what is that? Am I doing something wrong? Okay, then everyone, more psychologists, everyone assess social work. Then you find out that that person is breadwinner. He has 2 children who don't have, like he's worried if something happens to him, how they will continue their education. But that will be, he or she may find it difficult to express, okay, how to ask. That is why this team working will help. So when they find out and next day, like they talk to him and that is his worry, they find someone who is willing to help and they find someone who will take care of the education lifetime for the child. Next day, the same person, same medicine only, I have not changed any medicine, till his pain will come to 1. How? Because pain and mood have a strong wrong link. Low mood, high pain. All of you can, one day when you're all very upset, even the little toe pain will be 10 by 10. Next day, you're happy and jumping in joy. You will have an injury in your foot. But jumping in joy will not, you won't even consider. Anyone can tell me if what I'm stating or telling is right or wrong. Please. If it is wrong also, you can say. See, I won't eat anyone. Someone has said at least Sujata Singh. Right. Thank you.
Right,
So
ma'am.
this is common experience. Okay, go ahead. Pankaj. Pankaj wanted to say something, I think.
No, ma'am. I'm just saying that you are right.
Okay. Yes, very much. Because see, many times, no, we would have had, when what the example that I said, no, when you have an injury or something, until you were happy dancing, you wouldn't have known. When you come home and sit, oh my God, it hurts. Why did it not hurt when you were dancing with that broken or hurt leg? So our emotion overtakes us many times. Okay. Anyone has any queries, doubts, whatever it is, please go ahead and ask. Unmute, ask, or whatever you want to do is fine. So, like, how many of you see? Any of you, like you all said that you're all here to start the service. Am I right? That's what was told last time. Like in your setup, you're all planning to start palliative care service. That is what has brought all of you here, right?
Yes, ma'am.
Good, that's all. See, and one more thing I will again and again say, all of you attend the whole session and also try to have at least 5 or 10 days hands-on. Pallium will also help, and there will be centers in and around your place. Please go and have hands-on experience at least for 5 days or 10 days. 10 days will be ideal. There are centers which will be recommended by Pallium itself, and the regional coordinator from Pallium can help you to find centers. And many of you can go as groups. All friends can go together, like 4 or 5 of you get together, go have one change of place, get knowledge and some quality time together, enjoy and also learn. So, but hands-on is very important. All the lectures and everything that you hear will give you the knowledge, but you have to see to believe, and only by seeing seeing and doing something with patients, you will gain confidence. If you're not going to be confident, the patient also won't be confident with you. And especially in palliative care, we have to gain their support and confidence as early as possible. Why I'm telling as early, it may not and it cannot happen on day 1. Okay, so Those are important things. So it is only a combination which will work. One-way traffic will never work. Anything else anybody wants to say? Or any doubts in what I have? Is there any presentation, case presentations in here?
We don't have a presentation.
Okay, because just to make sure. All of you from next session onwards, try to bring up something. Never mind, as I keep telling, don't worry, never mind. Like it's all learning process. Like when only by doing something, bringing up your own queries. See, this is a platform, maybe many places you'll be by yourself. Here you've got 30, 40 people around. Will you get this all the time? So utilize this. If there are no queries, I will hand it over to you, Senior, or else anyone wants to ask anything, please go ahead.
I think there are no more further questions. So Snehalada, do you want anything to add on? Thank you all for joining for today's session. Thank you, Radha ma'am, for your support for last 2 days. I know that
sorry for all this.
No,
see,
you
this
need not say
internet,
sorry.
this technical